Good afternoon, one and all. I'm very thankful for having given me this opportunity. Today I'll be speaking about the accuracy of biometry using manual and automated keratometry for implant power calculation, cross-checked by the three-dimensional superformula. The aim of this study was to validate the accuracy of biometry using the two keratometric techniques, for which objectively the parameter that was taken into consideration was the percentage of patients having a post-operative spherical error within plus minus 0.5 diopters after implantation in each group. The inclusion criteria were as per LOCS 3 system, nuclear sclerosis grade 1 and 2 between ages 40 to 80 years, eyes with average axial length, and in the exclusion criteria, all nuclear sclerosis grade 3 and above were ruled out. Any coexistent ocular disease, intraoperative complication, surgical or ocular trauma in the same eye, or a refractive error amounting to plus minus 1.5 diopter or more in the pseudophakic fellow eye. We had 33 patients which were grouped in A and B groups. The first patient was allotted group A, and he was implanted an IOL of that power as we had calculated by using manual keratometric reading. While the second patient was allotted group B, he was implanted an IOL as assessed by using the automated keratometric reading in the biometry. And the third patient again fell in group A, and so on and so forth, till 33 patients were operated in each group. So the patients underwent cataract surgery by the triplanar scleral tunnel incision, 6.5 mm in size, with IOL placement in the bag. We compared the expected refractive error obtained pre-operatively during biometry, which is a value predicted by the A scan, with the residual spherical error in diopters, which we obtained at the end of 6 weeks post-operatively for both groups. A difference of these two above-mentioned values in diopters, termed as the absolute refractive error, was calculated individually for each operated eye at the end of 6 weeks, and it was entered in the Microsoft Excel chart for both the groups. For comparing the keratometric techniques, we chose the Bland-Altman plot, which is the difference plot, and it showed that the keratometric readings were comparable. The present study validated higher precision of automated keratometer for implant power calculation. When we considered the stratifications, we found that for an error less than or equal to plus minus 0.5 diopters, 81.81% people achieved this low error in the manual group, whereas in 87.87% people, which is much higher than 81.81%, they achieved a lower error. The mean spherical error also, correlated well with the other error. So in the automated group, the value was lesser. A comparison of the absolute refractive error in the two groups was the main outcome. If we considered less than plus minus 0.25 as the error, then only 57.57 people achieved this low error in the manual group, whereas 72.72% people achieved this low error in the automated group, which clearly shows that automated keratometer had an upper hand in biometric values. So comparison of the mean also showed that though statistically insignificant, there was a difference between the absolute refractive error for both the groups. Now, with this type of outcome, we tried to cross-check, as a surgeon, we tried to cross-check, and we found that Devgan et al. Have proposed different graphs which are specific for each IOL power formula. Only thing we have to do is we have to compute the axial length, the average K reading, and the calculated IOL power, and study where the dots fall. The dots should all lie within the shaded zone of the graph. So we concluded that this should be used pre-operatively. And if we are landing into any kind of IOL mishap, we will be warned pre-operatively so that we can cross-check again. So this was the plot we did for the manual and the automated group. You can see that on the plot used on the manual side, that is the left side, 3 points are falling outside and 1 point is the edge point. There are total 33 subjects in this group, whereas the graph on the right side shows only 1 point falling out and the other one is at the edge point. So definitely the number of errors were more on the manual group. So different people have come forth with different conclusions. Manning et al., Sundar Raj, Norse. Some claimed that automated keratometer could be a useful alternative, whereas some people felt that manual keratometry and both the techniques are equally precise. The conclusion we derived from our study was that all other variables for implant power calculation being comparable and statistically insignificant between the two groups, it is quite evident that automated keratometry is a more accurate device for biometry. And with implantation done based on biometry using automated keratometry values, not only is the residual spherical error smaller, but more number of people have achieved this. So to cross-check the precision of A-scan biometry, we have the three-dimensional graphs at hand. It is a very useful tool in the surgeon's armamentarium which can prevent IOL mishaps. So the take-home messages from the values of P were statistically insignificant in the absolute error. Still, from the surgeon's perspective, a happy patient is one who has a low refractive aid in the form of glasses, and therefore this was better accomplished in the automated keratometric group. Thank you for patient listening.
Hello, ma'am. Which machine was used and at what distance it was measuring keratometry for automated and for manual?
Yes, sir. So the manual is the gold standard which we mostly use in all institutions. It was the Bosch and Lomb keratometer, in which the chin position is rested. You get either the circular Myers or the step ladder pattern Meyer.
At what diameter it is taking the keratometry?
Pardon, sir?
At what diameter it is taking the keratometry?
Sir, I could not hear.
At what diameter it is taking the keratometry? 2 millimeter, 3 millimeter, 3.5 millimeter?
Sir, actually the automated keratometry that we were using, it was the KM100 of a Taiwan makeup, the company which had manufactured. In that we used to go 50 centimeter from the cornea. And the orange colored gold dots, they used to be focused on the cornea.
Now in the
machine,
manual they must have mentioned in this machine is measuring keratometry
yes,
at 2.2, 1.8, 2.3, what
sir,
level
it is the usual manual machine which takes only the central 2 millimeter of the cornea.
I doubt it, ma'am. Please check it again.
And second thing, who was doing the manual keratometry? Yourself, assistant?
Sir, the optometrist was doing, the person who does the biometry.
That's why we want to say that manual is substandard than automatic. We will not agree on this thing because we still rely more on the manual because we do ourselves. But they doubt, especially in the premium lenses, if there is a doubt in cornea pathology there, something there, we doubt on the automatic, then we go for manual, we do ourselves and we are more reliable. Even if there is confusion, then we can take between them. So manual is substandard than automatic.
Sir, I'm not saying that anything is substandard. Sir, when I cross-checked on the graph, only 3 points were falling outside the graph. Sir, statistics was all in, you have seen the tables. The values were all values, P value was insignificant, which meant that both the techniques are comparable, they are good enough, and we have been doing it all.
Request you next time.
Yes, sir.
You should, whenever there is a difference, manual and manual, you should do it yourself. Do not leave it on the optometrist.
Sir, actually, sir,
There is some hurry.
Sir, I only wanted to highlight that when the aim of my study was established, that time I was not even aware of these graphs which Devgan et al. Have proposed. When our results came out that the automated is showing better results, then we tried to cross-check कि दूसरे method से भी वैसा आता है क्या?
Ma'am, just go back and check into your manual of the automated and just find out at what level it is measuring the keratometry. So you will have.
Sir, I have gone through this. It is said that the manual takes only the central part of the cornea and the automated takes 3.5 mm of the center of cornea.
Correct.
And orange colored dots are formed, and if they are defocused, the machine gives a beeping sound and you don't take the reading.
Thank you, ma'am.
Thank you, sir. Thank you, sir.